in this case, hepatic arterial injury after a gunshot wound.
So the first step is getting access, catheter and guide wire being advanced up into the aorta. Next step is forming this reverse curve catheter. It turned out there wasn't enough space in the abdominal aorta, so the catheter is advanced into the thoracic aorta. Once the reverse curve is formed, guide wire is advanced, protecting the tip as the catheter is pulled down to the level of the celiac origin. Series of maneuvers to try and select the celiac. That probably was the celiac, but pulling down next is the SMA injection, so pushing back up, orienting anteriorly. There's the celiac, demonstrated with a puff of contrast, starting to center over the expected site of bleeding. Little puff to check before this DSA run. In the DSA run, you see a lot of distortion of the celiac and a little bit of underopacification in the segment of the liver where the injury occurs, but we don't see the extravasation. Microcatheter with really a double curve microwire being advanced into the celiac, trying to course over towards the right hepatic artery. Advancing the microcatheter, then the wire. Getting a little bit further. Now the wire's well into the hepatic, towards the right hepatic, getting close to the site where we want to do our check. Trying to get a little bit further, given that we know a good portion of the anatomy by the prior CTA. So not really getting the wire into the target vessel, but advancing the microcatheter a little bit further. You can see the base catheter being deformed when we put forward pressure on the microcatheter and guide wire. And now there's a check, and we're really at the base of the target vessel that we want to try and select. We don't see extravasation. And this DSA confirms the anatomy, but again, you don't see the extravasation, although there is a cutoff in that vertically oriented segment near the periphery of the liver towards the top left of the screen. And now, still with the double curve guide wire, trying to direct it into that branch. Pulling back the catheter a little bit. Sometimes this gives the wire the ability to curve a bit more, but actually we end up sort of losing territory, and we're going to have to regain it. So again, a lot of probing with the guide wire, and it's starting to get clear that maybe this isn't the right catheter and guide wire combination to select this vessel. So we've brought back the microcatheter a good deal, and again, going to have to regain that deep purchase into the right hepatic artery. And definitely know that we want to point the tip of that guide wire up, because again, we check and understand the anatomy, but for some reason this wire just is not working. Really spinning the guide wire, point it up. Boy, that looks like it should be able to slide into the target branch, but it's just not going. And this is a good example of really sort of confirming that we really just don't have the right combination of catheter and guide wire to select this branch. And so the next step will be switching to a different combination. So here's a check again, proving that we've got a patent origin. There might be a little bit of spasm at its origin now. But as soon as we switch to this guide wire with less of a curve, it immediately finds the branch, able to advance the microcatheter deep into that target branch. I'm going to try and get a little bit further. Again, we have a good idea of where the bleeding's coming from by the prior CTA. And now with this injection, yeah, you finally see the extravasation quite clearly. And the discussion is that whether we can try and coil on both sides or embolize on both sides of this bleed. And the feeling is no, we're going to use gel foam to get distally into that branch and then coil more proximally. So the first step is embolization with the gel foam slurry, and as we're embolizing, we see some reflux of contrast back along the course of the catheter and trying to minimize the flow into more proximal branches. Yeah, a good amount of reflux there, really to the origin of this branch. And now we've cleared the catheter and starting to coil embolize. It will take a series of coils back to the origin of this branch. So there's coil number 2. And coil number 3. Forming a pretty nice dense packing. Bringing the microcatheter back. Really unsheathing the last end of that coil. An injection to assess, and we're just going to see a little bit of contrast flowing through the coils and the gel foam and extravasation, and so we'll bide our time and go down and check our access site in the groin. Let a little bit more time pass, then come back, repeat the DSA, and because it's been a couple of minutes now, the coils and the gel foam, we now have complete occlusion with no further flow, no further extravasation. Pulling back the microcatheter because we want to inject more proximally and see if there are any other branches that feed this injured region. Puff followed by a DSA run. That nicely shows that we were able to completely occlude flow into the target region. We don't see extravasation from other branches. Going to pull back the microcatheter even further. Really trying to get all the way back to the origin of the common hepatic. Switching angles, and this actually, in retrospect, it would have made a lot more sense to go to an RAO projection rather than LAO, because in this LAO projection, the liver really is overlapping on itself, but we don't see any extravasation. The microcatheter is pulled out, and we're unforming the reverse curve catheter and removing it.